Hello, everyone, and welcome to the Guthy-Jackson Charitable Foundation NMOSD Grand Rounds. We welcome all attendees, and the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendation or advice on personal health. And of course, all patients and caregivers are advised to consult with their healthcare team for specific information. NMOSD Grand Rounds has several overarching goals. First, it's a practical summary of the latest information on the topic. It's designed to emphasize key themes and clinical pearls, and is intentionally inclusive of non-specialist audiences. There's a pocket guide at the conclusion of the presentation that highlights specific information as a reference. NMOSD Grand Rounds is eligible for continuing medical education activity. To earn activity, please proceed to the GJCF Education Center using the QR code shown here. Select the session and register for continuing medical education, and view the session and fulfill the CME requirements. Receive the certification online. My name is Dr. Michael Yeaman, and I am an advisor to the Guthy-Jackson Charitable Foundation. And it is my privilege today to introduce Dr. Hisham Abood. Dr. Abood is Associate Professor of Neurology at Case Western University, and he will present today our summary of NMOSD Grand Rounds focused on managing day-to-day non-relapse symptoms. Dr. Abood, Hisham, thank you so much, and we really look forward to your presentation.
Thank you very much, Dr. Yeaman, and thank you everybody for joining in. First, we'll start by some general principles about the non-relapse symptoms of NMOSD. The majority of these symptoms are basically residual symptoms due to incomplete relapse recovery. For example, visual impairment after optic neuritis or motor weakness after transverse myelitis. But some are expected long-term sequelae to the lesions in the spinal cord or the optic nerve or the brain, for example, developing spasticity following transverse myelitis. Some of the symptoms are basically reactive symptoms to existing disability. For example, feeling depressed or anxious because of the neurological symptoms. Some may also result from relapse-independent disease activity or progression between relapses, which is extremely rare in NMOSD, but reported in a few case reports. And then there are some symptoms that are basically a little bit hard to determine their origin. They are likely multifactorial, things like fatigue and cognitive symptoms in NMOSD patients. Now, one important aspect of today's presentation is that there are really no clinical trials for symptomatic management of NMOSD. So most of the evidence behind the medications or the interventions that we will be discussing are basically borrowed mostly from MS or other spinal cord disorders. So these are the symptoms that we will cover today. These are some of the most common and problematic non-relapse symptoms in NMOSD. Starting with neuropathic pain, we'll go over spasticity and other muscle tone disorders, tonic spasms, and other spinal movement disorders. We'll discuss sphincteric disorders, fatigue, sleep disorders, psychiatric and cognitive symptoms, and then we'll also discuss motor and visual impairment. So first, we'll start with neuropathic pain. This is one of the most common non-relapse or ongoing symptom in NMOSD patients, affects about 85% of the patients. It has definitely significant negative impact on the quality of life due to the pain. It mainly follows spinal relapses, but also possible following brainstem relapses or thalamic involvement in the brain. It may be associated with something called neuropathic itch, where the patient feels itchy and starts scratching at the location where the neuropathic pain is. This sometimes happens as a manifestation of the actual relapse, or it can be a residual symptom as well. Neuropathic pain typically responds to medications that act against neuropathic pain, similar to what you use for diabetic neuropathy, for example, including gabapentin, pregabalin, and tricyclic antidepressants, and also serotonin noradrenaline reuptake inhibitors like venlafaxine or duloxetine. Although opioids may work, they usually are not superior to the other agents, and they cause a lot of side effects. So we try to avoid them as much as possible. Now, if you have refractory neuropathic pain, neuromodulation is an excellent option, and there are several approaches to neuromodulation of neuropathic pain. One of them actually has strong evidence behind it, which is scrambler transcutaneous electrical stimulation therapy, which showed positive impact on neuropathic pain, depression, and anxiety in a randomized controlled trial, specifically in NMOSD patients. On the left side, this is a picture of scrambler therapy. You basically put several pairs of electrodes around the area where the neuropathic pain is, and you stimulate this with an external stimulator, just like a TENS unit. And you do this daily in the clinical trial published in 2020 by Mealy and colleagues. This was done over a 10-day period, and it was a randomized controlled trial, also blinded, and it showed significant benefit in neuropathic pain. Scrambler therapy usually is provided by pain management specialists, but it's not available everywhere, but it is worth looking into for your refractory patients. A more traditional neuromodulation technique for neuropathic pain is spinal cord stimulator, in which there is an implanted battery or intermittent pulse generator implanted subcutaneously, usually in the lower back, and it is connected to a number of electrodes or electrode grids that are intrathecally implanted to stimulate the dorsal column and reduce pain through the gate theory. We'll now shift to muscle tone disorders, most commonly spasticity, which affects about 52% of NMOSD patients, which is a higher prevalence compared to MS, given the higher prevalence of pyramidal tract affection and myelitis in NMOSD patients. Spasticity can have several negative impacts on mobility. It can cause pain. It can increase the risk of skin breakdown, pressure ulcers, and it can have negative cosmetic and, most importantly, social effect on the patient. But it also has some benefits because it compensates for weakness. It can preserve muscle mass, prevent muscle atrophy, and it also improves venous return and decrease the risk of DVT. So when you treat spasticity, you want to avoid over-treating spasticity. Some spasticity is beneficial. You do want to bring the muscle tone down to a level that is comfortable for the patient, that is beneficial for the patient, but not necessarily remove the muscle tone completely. There is a constant component to spasticity, which is that stiffness component that you typically see in patients' lower extremities, sometimes in the upper extremities as well. But there's also a phasic component, meaning a transient increase in muscle tone that comes on suddenly, then disappears. And this is what we call tonic spasm. And this is a very common NMO symptom that we will discuss separately, but it is really a form of spasticity as well. Rarely, NMOSD patients can actually have hypotonia, so lower muscle tone, or they can have mixed hyper and hypotonia due to affection of the anterior horn cells in the spinal cord, or due to advanced disease and spinal cord atrophy. So when you evaluate the patient, make sure that you check all the limbs, all the muscle groups, and then identify which areas are spastic and which areas might be hypotonic, and avoid over-treating or treating those patients with hypotonia. So how do we manage spasticity? First, there are some non-pharmacological measures. These are actually the most important. You want to identify and prevent any cause of temporary worsening of the muscle tone. Some of the most common causes for this are urinary tract infections, untreated constipation or stool impaction, uncomfortable temperature where the patient resides, uncontrolled pain. All of these factors will make spasticity worse, and they are all treatable or preventable, so make sure you address those first. Daily stretching, doing basically range of motion exercise around each joint is extremely important. It's probably the most important intervention for spasticity. And no matter what pharmacologic or neuromodulation technique you use, stretching remains very, very important to make these interventions actually effective. Physical therapy, occupational therapy, exercise, these are all extremely important as well. Now, for pharmacological treatment, we have oral antispasticity agents. There are injectable, especially botulinum toxin injections. There is a neuromodulation technique, intrathecal baclofen pump, which we will discuss briefly. And then in refractory cases, we've also done nerve blocks, phenol or alcohol nerve blocks to interrupt the reflex arc and bring the muscle tone down completely in some problematic cases. These are examples of the oral antispasticity agents that are typically used. Baclofen, of course, is the most common. It has a central action, acts on GABA B receptors. The maximum dose is 80 milligrams per day, but it can cause weakness by unmasking that weakness that happened by removing the muscle tone. So be careful when dosing baclofen. It is also a sedating medication. Tizanidine acts on alpha-2 adrenergic receptors, and its maximum dose in adults is 32 milligrams. It can also cause sedation and hepatotoxicity. Dantrolene acts a little bit differently. It's a peripheral acting muscle relaxant. It acts by preventing calcium release in skeletal muscles. And its maximum dose is 400 milligrams, but it can also cause weakness and hepatotoxicity. Cannabinoids are not FDA approved yet for spasticity, but are expected to be in the near future, and they might be good add-on treatments for spasticity as well. Benzodiazepines, although they can have benefit against spasticity, there is at least a theoretical risk that they might worsen NMOSD or result in relapses due to overexpression of aquaporin 4 water channels on the surface of astrocytes when stimulating the GABA-A receptor. So in general, because of this theoretical risk, we try to avoid benzodiazepines in NMOSD patients. Now, for refractory cases, advanced spasticity management really starts with botulinum toxin injections. These are usually best for areas of focal spasticity. If there is a specific area that is especially problematic, you can address 1 or 2 muscles with botulinum toxin, which brings the muscle tone down and has a lasting effect for up to 3 months, and then it has to be repeated if beneficial. These are some examples of upper extremity spasticity or upper extremity focal spasticity that we can use botulinum toxin injections for. In that first panel, you see someone with abducted shoulder, which can cause significant problems in accessing the axillary region or cleaning that area. And in those cases, we typically do injections to the pectoralis major muscle. For elbow flexion, we inject the biceps. For pronated forearm, we inject usually the pronator teres. For flexed wrist, we inject the flexors of the wrist, the FCU and the flexor carpi ulnaris and radialis. And then if there is finger flexion, we address the finger flexors, flexor digitorum superficialis or profundus. What you see more commonly in NMOSD patients is lower extremity focal spasticity, especially of the Achilles tendon, as you can see in that first picture. So the patient has foot drop due to weakness, and then the foot drop becomes more fixed in place when the spasticity sets in. And this is easily addressed with the botulinum toxin injections to the gastrocnemius and the soleus muscles. Sometimes patients have an extended knee, hard to bend, which makes transfers very difficult. And in those cases, we can inject a small dose of botulinum toxin to the quad muscle. But be careful in ambulatory patients because they do need this extensor tone to ambulate. So you want to avoid large doses in this muscle. In patients who've been in a wheelchair for a long time, they develop this flexed knee posture for which hamstring injection is usually very effective. And in those who have scissoring gait or severe adductor spasms, making access to the perineum difficult, injection to the hip adductors usually is very successful in alleviating this type of spasticity. Patients with curled toes, we inject the flexor digitorum brevis and longus. Patients with striatal toe, where the big toe keeps extending up, making walking difficult, we inject the extensor hallucis longus. And then for inversion of the foot, we inject the tibialis posterior and sometimes the tibialis anterior if there's no accompanying foot drop. Now, if the patient is refractory to both oral and injectable interventions, we've referred a number of patients for intrathecal baclofen pump, which is a neuromodulation technique that also involves pharmacologic intervention. Basically, in intrathecal baclofen pump, there is a battery that is also a reservoir that is implanted subcutaneously, usually in the lower abdomen. And it is connected with a catheter that is surgically implanted in the middle or the upper thoracic spine. And you fill that pump with liquid baclofen, much lower concentrations than what you need orally to achieve the same effect. And you can program this pump to give continuous flow of liquid baclofen into the spine in order to relax the muscles, typically mostly below the level of the insertion, so mostly affects the lower extremity. But it does mix with the cerebrospinal fluid and circulates, so it can have some benefit on the upper extremities as well, but usually less so compared to the lower extremity. You can also program this pump to give boluses throughout the day according to the need of the patient. In studies comparing baclofen pump to injectables and orals, it has been shown that baclofen pump is actually superior than the other interventions when it comes to tonic spasm control, which is a big problem in NMOSD patients. So it's a very useful intervention, very underutilized in NMOSD patients, although they probably need it the most. Now we'll talk about tonic spasms in particular, and also other spinal movement disorders that are generated at the level of the spinal cord. Tonic spasms are very common. They actually some of the most problematic non-relapse symptoms that NMOSD patients suffer from. It affects about 43% of the total NMOSD patients. But if you exclude those who only have optic neuritis and focus on those who had transverse myelitis, then among transverse myelitis NMOSD patients, the prevalence is actually extremely high. It's about 83% of those patients will have tonic spasms. When compared to MS and MOGAD, NMOSD patients have significantly higher prevalence of tonic spasms. This includes even prospective studies that followed patients over time. The tonic spasms commonly develop a few months after recovery from myelitis, although in a minority of patients, it can actually start with the onset of the relapse. But in most cases, on average of 1 up to 4 months is when they start appearing. Against the common misconception, not all of them are painful. I know that literature usually uses the term painful tonic spasm. Actually, only about 1/3 of those spasms are painful. The majority are actually painless, but they still have a significant negative impact on patients, including negative impact on mobility, on balance. They can predispose to falls. They can interfere with the ability to drive, to sleep, and they can also lead to skin injuries. The phenotypes of the tonic spasms in NMOSD, they can be isometric. That's the most common. An isometric spasm is a spasm that would not cause any gross movement of the limb or the body part that is affected, but you can feel the muscle contracting and tightening. This tends to be the most painful of all the tonic spasms, and we very commonly see it in the truncal muscles in NMOSD patients. You can also have extensor spasms, especially around the knee, flexor spasms. We see it mostly in the upper extremities around the elbow, adductor spasms, or complex spasms where more than one of these phenotypes happening at the same time, sometimes involving multiple limbs at the same time. In addition to tonic spasms, myelitis in NMOSD patients can cause a variety of other involuntary movements, including focal dystonia, which can be fixed or paroxysmal, spinal tremor, spinal myoclonus, which also can be focal or more generalized. We call it propriospinal myoclonus. It can cause spontaneous clonus, so clonus in the ankle or the knee or the hip that is not induced by the physician. It's just triggered by movement or by touching something cold or a variety of other triggers. And of course, can also lead to acquired restless limb syndrome. Why do tonic spasms and other paroxysmal involuntary movements happen in NMOSD? We don't know for sure why they happen, but there is one popular theory, something called ephaptic transmission of nerve impulse. What you can see on the left-hand side is a normal axon, myelinated axon, where the nerve impulse goes vertically from the nerve cell body down to the foot process and then jumps to the next neuron. But if there is demyelination, which as we know is a secondary phenomena in NMOSD, then this nerve impulse is allowed to move horizontally from one neuron to another, including neurons that you did not intend to move. So you think about moving your left leg, for example, but then the nerve impulse jumped to another neuron and it leads to a spasm in the other limb. Or you want to move the foot and it leads to a spasm in the hip, for example. And this theory is the most acceptable for why tonic spasms and paroxysmal dystonia happen very frequently in NMOSD patients. Have some videos here of examples of tonic spasm. This is an NMOSD patient who's completely paraplegic. There's really no strength at all in the lower extremities, but is suffering from near constant ankle dorsiflexor spasm, as you can see, which can be very uncomfortable, makes positioning in the wheelchair very difficult. They had to put all these belts to keep the foot from sliding. This is an example of a patient with LATM who has, again, near constant adductor spasms in both lower extremities, despite really having no strength at all. Again, this is a paraplegic patient, zero motor power, but they keep having these adductor spasms all the time. And as you can see, it can be very uncomfortable or very inconvenient for the patient. This is an example of an NMO patient with right hand dystonia. You can see the left hand is very good, and then the right hand is very clumsy. It also has a subtle abnormal posture. It's very interesting. This patient would get this paroxysmal dystonia in the form of episodes lasting for a day or two. And then in between the episodes, she's completely normal. And you can see her cervical MRI. This is more of a chronic picture. Post-LATM, you can see remnant of her longitudinally extensive myelitis in the cervical region. This is a similar patient, also NMOSD with focal dystonia in the right hand, also from cervical myelitis. But you can see that she also has a dystonic tremor that happens when her paroxysmal dystonia kicks in. And this is an NMOSD patient that's an antibody negative patient who also have cervical myelitis and developed this postural tremor in the fingers and the hand following recovery from myelitis. Patient also has a little bit of a dystonic posture as well. So how do we treat tonic spasms and other spinal movement disorders? Most case series and retrospective studies suggest that sodium channel blockers, anti-seizure medications like carbamazepine, oxcarbazepine, or even phenytoin are the most effective against tonic spasms. That's especially true when they happen outside of spasticity. So keep in mind that tonic spasms can happen in someone who's not spastic yet. And when you see a non-spastic patient with tonic spasm, usually carbamazepine or other sodium channel blockers are the best treatment approach. But when this patient develops spasticity later on, if they do, and they still continue to have tonic spasms, then you do want to add a muscle relaxant like baclofen or tizanidine. Some investigators suggest that tricyclic antidepressants or SNRIs also have benefit against tonic spasm. I have not used them personally, but it's been reported in literature. And then if the tonic spasm is very stereotypic, meaning the patient always gets the same tonic spasm, it's always an elbow flexor spasm, for example, then you can address this with botulinum toxin injection to the biceps or whatever muscle is producing that tonic spasm. As I mentioned earlier, intrathecal baclofen pump has been shown to be more effective against spasms than oral and injectable agents, especially if the patient has complex or diffuse tonic spasms in both lower extremities. I find it very useful to refer those patients to intrathecal baclofen pump, and sometimes the tonic spasms disappear completely. However, in about 40% of cases, tonic spasms and other spinal movement disorders remain refractory to treatment, and they do require clinical trials to see how we can address this very problematic and highly prevalent non-relapse symptom in NMOSD. We'll now switch to sphincteric dysfunction, basically referring to bladder, bowel, and sexual dysfunction, which collectively are very, very common in NMOSD patients, affecting about 78%. For the bladder, both hyperactive bladder or hypoactive bladder can happen, sometimes even mixed picture. So it's more complex than your typical MS patient, for example. Urodynamic studies in NMOSD patients show sometimes non-contractile detrusor or hyperactive or neurogenic detrusor. and with or without sphincter dyssynergy as well. Bladder dysfunction can lead to stagnant urine, which can increase the risk of UTIs, kidney stones in the bladder, and can cause back pressure in the kidneys, causing hydronephrosis and sometimes even kidney impairment. So it's a very, very serious condition that needs attention of the clinician. Bowel dysfunction can lead to constipation, sometimes very severe, leading to stool impaction that requires ER visits and so forth. So this is very, very important. And then also stool incontinence can happen either as a primary phenomena or as an overflow stool incontinence due to stool impaction. Erectile dysfunction in men and sexual arousal disorder in females are also relatively common. So basically, all sphincteric function can be affected in NMOSD patients with myelitis. So how do we address those symptoms? Again, there's non-pharmacologic approaches, proper timing of fluid intake, pelvic floor exercise, intermittent self-cath to make sure there is no stagnant urine and to avoid incontinence. These are very common measures that most NMOSD patients with sphincteric dysfunction do on a regular basis. There are some pharmacologic interventions. If the patient has mostly hyperactive bladder with urinary incontinence, you can use antimuscarinic agents like oxybutynin or darafenicin. Also selective beta-3 adrenergic receptor agonists like mirabegron, or even botulinum toxin injection to the bladder muscles. For constipation, simple things like high fiber intake, laxatives, bowel stimulants, stool softeners are very important to keep regular bowel movements. And then for erectile dysfunction in men, we use phosphodiesterase inhibitors like sildenafil for sexual dysfunction. Might be helpful in some patients. However, the most success we really get in our center is with neuromodulation, and there are different forms for neuromodulation to help. And these techniques, whether the posterior tibial nerve stimulation or the sacral neuromodulation, also known commonly as the bladder stimulator, these don't only act for the bladder dysfunction, they are actually excellent in controlling bowel dysfunction as well. And we do refer a lot of patients for these neuromodulation techniques. Your last resort, of course, is indwelling catheter or a suprapubic catheter for bladder dysfunction, or a permanent colostomy for bowel dysfunction. And some NMOSD patients do require these, and they can really have a very significant impact, preventing things like kidney impairment or stool impaction and ileus, for example. These are examples of neuromodulation technique. The most common and most popular is the sacral neuromodulation or the bladder stimulator, where an intermittent pulse generator is implanted subcutaneously, usually in the lower back, and it connects to the sacral nerves that control the bladder function, and they cause basically a continuous stimulation of these nerves in order to regulate the bladder function. There's also the posterior tibial nerve stimulation. This is a non-invasive technique. So the patient basically comes to an outpatient facility and gets sessions daily or every other day, or sometimes even less frequent than that, with a transcutaneous stimulation of the posterior tibial nerve, which causes an antidromic activation of the sacral nerves that control the bladder as well. And studies in MS showed that both techniques really are almost equally effective. However, most patients really choose the implanted option because it's more convenient, less hospital visits. And they are actually MRI compatible nowadays, so you can still get MRIs if needed for your NMO monitoring. We'll now talk about fatigue. Again, very common, affects about 70% of NMOSD patients. It tends to be mostly physical fatigue in NMO as opposed to the mental fatigue, which is more common in MS patients, probably due to less involvement of the cortex in NMOSD patients. Management, again, focuses on things first that might be contributing to the fatigue. If the patient has a sleep disorder, you want to address that. If the patient has depression, improvement of mood can improve fatigue. If the patient is on maximum dose of baclofen or a combination of several muscle relaxants, for example, maybe the patient doesn't need that much. I've seen patients who are really hypotonic on exam and they are on maximum doses of baclofen. So when you start cutting down baclofen, their fatigue actually might improve, and even their muscle strength sometimes improves. Exercise, light exercise helps fatigue, and aquatherapy is something that we're referring more and more patients to, and a lot of the patients really like it when it comes to fatigue mitigation. For mental fatigue, cognitive behavioral therapy can be helpful as well. And then there are some pharmacological options, again, borrowed from the MS field, things like amantadine, also stimulants like modafinil or methylphenidate. They might help fatigue on an individual basis, but keep in mind that in MS, recent clinical trial showed that none of them really have any benefit over placebo. So there is evidence that they don't work, but on individual levels, sometimes they do help. And we nowadays really restrict our use to amantadine since it's not addictive. Also, bupropion, which is a dopaminergic noradrenergic reuptake inhibitor used as an antidepressant. It's a stimulant antidepressant, and we've had some success in managing physical fatigue with this agent as well. There are some reports of the use of transcranial magnetic stimulations. This is a non-invasive neuromodulation technique for fatigue with some success in some reports. I have not used that, but it's something probably worth looking into in the future. Sleep and respiratory disorders. We are all familiar with the rare but very problematic diencephalic attacks that happen sometimes in NMOSD patients, sometimes leading to acute sleep disorder as part of the relapse. But following those attacks, patients can also develop chronic sleep disorders that last long even after recovery from the attack, including acquired chronic narcolepsy or excessive daytime sleepiness that might respond to modafinil, the same agent that you use for idiopathic narcolepsy. Sleep disordered breathing is actually more common in NMOSD patients than MS in healthy control and may require the use of CPAP machine at night. Acute respiratory failure due to high cervical myelitis can happen as part of acute relapse, but it can be followed by chronic respiratory failure and acquired central sleep apnea. And these we've addressed here in our center in a few cases with a diaphragmatic pacer, which I'll show you a picture of in the next slide. Insomnia in NMOSD patients is more commonly reactive due to mood disorder or adjustment disorder after attacks and can respond to sedating antidepressants like mirtazapine or amitriptyline, for example. And then we already discussed restless leg syndrome, which is both a movement disorder, but also a sleep disorder that is very common in NMOSD patients and can respond to gabapentin. This is a picture of that diaphragmatic pacer. This is an external stimulator, typically not implanted. You just wear it. But the electrodes are implanted to stimulate the phrenic nerves or directly on the diaphragmatic muscle in order to cause a constant or regular contraction in patients who had diaphragmatic paralysis due to severe cervical myelitis. This can typically prolong life up to about a year or two, and sometimes patients improved over time, but we find it useful in those highly problematic patients who have a very, very high mortality rate, unfortunately. Psychiatric and cognitive symptoms, depression, suicidality, and cognitive impairment are more prevalent in NMOSD patients compared to healthy controls. Treatment, of course, is with antidepressants like SSRIs, tricyclic antidepressants, which can improve not just the mood, but also cognition. Treatment of fatigue and sleep disorder is very important in order to address the psychiatric symptoms and cognition. Again, reduction of unnecessary polypharmacy, especially sedating medications, can improve cognition. If the patient developed cognitive impairment acutely following a cerebral relapse, which is rare in NMOSD patients, but it can happen, then those patients, you can also refer them to a neuropsychologist with expertise in cognitive and neuropsychological rehabilitation, just like your TBI patient, for example. And we've had some success with this very comprehensive and involved approach to patients with cognitive impairment. The role of Alzheimer's medications like donepezil or benzotropine is not really known in NMOSD, and I've not used it and I haven't seen any literature on it, but it's something worth looking into in the future. Lastly, we'll talk about residual motor weakness and visual impairment. Of course, this is relatively common after optic neuritis attack for vision or myelitis attack for mobility. Overall, about 34% of NMOSD patients develop permanent motor dysfunction, with 23% becoming wheelchair-bound after a median disease duration of 75 months. There is no specific pharmacologic intervention for weakness. The treatment really relies on neurorehabilitation, physical therapy, sometimes functional electrical stimulation with FES-based exercise equipment can help. And then to improve walking speed, we've tried dalfampridine, which is FDA-approved in MS patients to improve walking speed. Sometimes it can be helpful. There's a small case series in NMOSD patients with positive effect. And also there's a case series in transverse myelitis patients with borderline benefit as well. As for visual impairment, again, there's really no pill to help that. It affects up to 40% of NMOSD patients following optic attacks. But for both motor weakness and residual visual impairment, some promising future options include brain-computer interface, which can be either motor or sensory, utilizing advanced technology to compensate for these neurological deficits. These are things we've always seen in literature as single case reports here and there. But in more recent years, really, they may become reality and commercially available very soon, with many companies looking into BCI technology for commercialization. Remyelinating agents and most importantly, mesenchymal stem cell transplantation might help with neuroregeneration for motor and visual impairment, although these remain experimental at this point. So at the end, I have just a few clinical pearls. For medication-refractory neuropathic pain, consider referral to pain management for scrambler therapy or spinal cord stimulator evaluation. Many clinicians focus mostly on pharmacologic treatment and forget that neuromodulation is very effective and probably even safer than medications. And we need to utilize neuromodulation more for our NMOSD patients. For medication refractory spasticity, remember, you can refer those patients for botulinum toxin injections, also for intrathecal baclofen pump evaluation. And then remember that your patient might also have hypotonia intermixed with spasticity, or some NMOSD patients don't have any spasticity at all. They're actually hypotonic, so be careful with that. For tonic spasms, use carbamazepine or oxcarbazepine first, and then if spasticity sets in, add baclofen and tizanidine. Keep in mind that bladder dysfunction NMOSD is very complex, and it's best to be guided by a urologist and a urodynamic study, because patients can have both hypoactive and hyperactive bladder dysfunction. Also keep in mind that fatigue, sleep disorders, cognitive impairment, and depression are all interrelated, and treatment of each of these symptoms can have benefit for the others. So very, very important to keep that in mind. This is a pocket guide here of some of the most commonly prescribed symptomatic medications in NMOSD patients. Remember that many of these agents can have more than one benefit. For example, your gabapentin can be used for neuropathic pain, but it also has some benefit against tonic spasm. And in that pocket guide, you can see the maximum dosing of these medications, the typical side effects, and also the class of evidence that is typically borrowed from spinal cord injury or MS, but some of these medications have some evidence in NMOSD as well. Carbamazepine used for tonic spasms and neuropathic pain. Baclofen, as mentioned, for both spasticity and tonic spasms. Duloxetine might have benefit against neuropathic pain, against depression and anxiety, and even tonic spasms, according to some investigators. Amantadine, oxybutynin, and dalfampridine, as discussed. And you can see more details about the symptomatic therapies in a publication from 2021 by the Guthy-Jackson International Clinical Consortium that we published in the Journal of Neurology. A lot more details about all the symptomatic approaches to NMOSD. And that basically concludes the presentation, and I'll be more than happy to take any questions.
Hisham, thank you so much for the excellent review of interventions and management of non-relapse symptoms in NMOSD. We'd like to take a few minutes now to go over a couple of questions. The first one focuses on your approach to treating a patient with mixed hyper and hypotonia. And as you mentioned, that occurs more frequently than might be apparent otherwise. But if you could just review your approach in a situation like this.
Yeah, so those are really relatively difficult to manage. The most important thing is to avoid over-treating spasticity in those patients. So you want to avoid very high doses of oral baclofen. You don't want to put a baclofen pump for someone who has hypotonia in their lower extremities, for example, because this is going to be much worse. I usually find botulinum toxin injections to be the best approach in those patients because it's so targeted, it's so focal that you can isolate the muscles that are spastic and inject them without affecting the hypotonic muscle. So that usually is my preferred approach to those patients. I can still keep them on a small dose of oral baclofen, but definitely would avoid high doses.
Excellent, thank you. Another question relates to how you would approach treating spinal movement disorders other than tonic spasms, and you differentiated those in your presentation.
Yes, and it's an excellent question. So the movement disorder field in general focuses on phenomenology. So you want to address each movement disorder based on what the phenomenology is, and you borrow this from the idiopathic counterparts of these involuntary movements. For example, if someone has spinal myoclonus, you would add an antimyoclonic agent like valproic acid or levetiracetam, for example, to address myoclonus. If they have spinal tremor, typically, in most cases, it is a postural and kinetic tremor, similar to what you see in essential tremor patients, for example. So you can try propranolol, primidone, or topiramate for those patients. Dystonias, if it is paroxysmal dystonia, typically you would approach it just like a tonic spasm with carbamazepine or oxcarbazepine. Or if it's very stereotypic, or if it's a fixed focal dystonia, then again, botulinum toxin injection would be the best approach.
Excellent. Thank you for that clear approach. Hisham, let's talk a little bit about neuromodulation, which you emphasized is probably underutilized in NMOSD. What are some special precautions when you're applying neuromodulation techniques in NMOSD patients?
Yes, so the most important thing is to make sure that whatever is implanted is MRI compatible. You will need MRI for your NMOSD patients whenever there's a suspected relapse, for example, or even suspected CNS infections because of the medications that we use to treat NMOSD. So you want to make sure that when you refer the patient to emphasize that whatever is going to be implanted, whether it's a spinal cord stimulator or a bladder stimulator or a baclofen pump, that it must be MRI compatible and typically compatible with whole body MRI because you will need spine MRI in NMOSD patients. This is very, very important. The second thing, which is also extremely important, is you need to notify the surgeon that or the pain management specialist that those patients are typically on immunomodulating agents, sometimes immunosuppressant agents, which increases the risk of infection, including hardware infection, which is a big problem in neuromodulation. So unlike, for example, somebody who's getting a spinal cord stimulator for a failed back syndrome or chronic low back pain, your NMOSD patients might be on a B-cell depleting therapy or a general immunosuppressant, and extra caution must be taken during surgery and afterwards to avoid hardware infection. The last thing I can think of is sometimes the tonic spasms that NMOSD patients can be very violent, that they can actually cause a break in a baclofen pump catheter or in the electrodes of a spinal cord stimulator. So I typically like to control the tonic spasms first before we implant anything, especially if they are very violent.
Excellent practical advice, Hisham. Thank you very much. You talked about emphatic transmission of these kinds of conditions, and
agents, not in MS and obviously not in NMOSD. When they become available, if they become available, they probably will be beneficial in NMOSD. The main concern with NMOSD is that demyelination is not the primary process as opposed to MS or even MOGAD. And that's why if these agents become commercially available, we expect some benefit, but it's probably not going to be groundbreaking or as impressive as it would be in MOGAD or MS, for example, because really the primary pathology is astrocytopathy rather than demyelination. So they may be of help, but I think we should focus a little bit more on neuroregeneration when it comes to restoration of function in NMOSD patients.
That's a great point, and it is a perfect segue to the next question, Hisham, which has to do with, what's your view of the most pressing need for future research in these areas, symptomatic and restorative or regenerative therapies for NMOSD?
Yes, and yeah, I think the most important is really neuroregeneration research, which is the most important topic in all neurology, really. That's not specific for NMOSD. Mesenchymal stem cell transplant, obviously, if it ever pans out, will be of great help to our NMOSD patients because of the residual motor and visual impairment that they have. More practically speaking, as I mentioned, I think protein-computer interface as a restorative approach to motor weakness or visual impairment. I think this is a more kind of lower hanging fruit at this point, since a lot of commercial entities are interested in BCI technology, and I think this might be very, very beneficial to our NMOSD patients. We probably should invest in some of these approaches. And then lastly, for, tonic spasm is my favorite topic, and I think having an actual symptomatic clinical trial for tonic spasms and other spinal movement disorders, I think, is also very, very important in NMOSD.
Hisham, thank you so much for the excellent points about the future research in symptomatic and restorative NMOSD management. We have time for a few more questions. And so what I'd like to do is maybe ask you to offer your experience in the idea of personalizing both interventional and behavioral approaches to managing non-relapse symptoms. For example, in the Pocket Guide, many of the therapeutics you mentioned have pretty wide dose ranging. And so I guess the idea is, how do you customize treatment for a specific patient on sort of a case-by-case basis?
Yes, this is an excellent question. And I think there are two aspects that I usually look at when putting a symptomatic plan for NMOSD patients, or really any neurologic patient for that matter. One is start low and go slow. Symptomatic treatment really is for patient convenience. All of these symptomatic medications have side effects that can be inconvenient. So you do want to use the lowest possible dose that would address the symptom without burdening the patient with the side effects. You want the lowest baclofen dose to address the tonic spasm and spasticity without causing excessive sedation or weakness, for example. So start low and go slow is the first aspect. The second thing I take into account typically is the patient themselves. What are they like? What are their comorbidities? Am I going to hurt something else when I add this particular symptomatic medication or the other? So that also factors in, not just in the selection of the medication, but also on the dose. So you don't want to underdose somebody with a higher BMI or overdose somebody with a lower BMI, or cause interaction with the other drugs that they are in. So these are usually the two principles that I follow when selecting agents and when determining the dose that the patient will be taking.
Thank you so much. So important that all of these things are considered. And in that respect, Hisham, there sometimes is a tendency to kind of create a treatment regimen and put it in place and then not really review it periodically. People change over time, including aging and other things. If you could just offer a few comments about the interval that you would recommend for reassessing need and therapeutic approaches to non-relapse symptoms?
Yes, this is actually an excellent point, and it relates to some of the themes that we discussed during the presentation. I've seen, for example, NMOSD patients or MS patients who come to clinic, and they are on 80 milligrams of baclofen, and they've been on that maximum dose for 5 years, 6 years, or sometimes even a decade. And when you examine them, they really have no spasticity at all. And they are complaining of fatigue, they're complaining of mental fogginess. The muscle tone might be normal or low because of the treatment, obviously, but it also could be that the patient is no longer spastic. They develop spinal cord atrophy. They no longer really need baclofen. So it is really important in those patients to try to cut down. You have to do it gradually, obviously, and reassess. And for the frequency of reassessment, really, ideally, it should be with every visit. So if you're seeing an NMOSD patients twice a year, I'm talking about a stable NMOSD patient, then they really should be assessed during the visit with at least a brief neurologic exam, just to make sure, do I still need the baclofen? Do I still need medications for tonic spasms? They might no longer have tonic spasms. So these are very, very important, and it kind of relates to that polypharmacy reassessment that I mentioned, because they can have a lot of negative impact, and sometimes simplifying the medical regimen actually has more benefits over having, a list of 10 or 12 medication for each patient. So I totally agree that reevaluation, reassessment, repeat neurologic exam is very, very important for the symptomatic management of our NMO patients.
Great points, Hisham. Thank you so much. And finally, we know that patients rely to a large extent on caregivers who are often underappreciated, but the idea that some of the symptoms of NMOSD that are non-relapse related can be greatly benefited by caregiver support. And maybe just a couple of comments in your view about that point, Hisham, please.
Yes, this is, again, extremely, extremely important. When we were discussing the symptom categories, almost in every symptom, we started off with the non-pharmacologic approaches. And these non-pharmacologic approaches are with the bowel regimen or bowel interventions, and without a caregiver, I think these things are impossible. I believe really that a good caregiver, an attentive caregiver, a skillful caregiver, resourceful caregiver is really one of the most important things for a good quality of life of our NMOSD patients. And we see this in clinic very clearly, that patients with a good support system, with either caregivers that are related or professional caregivers, they do way better than someone who has less of these resources. So really hats off to all caregivers. We cannot thank them enough. And they can also be affected really by whatever comes with NMOSD in terms of the burden. And they really have to also take care of their own mental health and take breaks and take care of themselves in order to be strong enough to care for their loved ones or their relatives with NMOSD.
Excellent points, very practical. Hisham, thank you very, very much for this great presentation.
Thank you.
With that, we want to thank Dr. Hisham Aboud, Associate Professor of Neurology at Case Western University, and remind everyone in attendance that the presentation you just saw is eligible for continuing medical education activity. To achieve this, please visit the Guthy-Jackson Charitable Foundation Education Center using the QR code shown here. Select the session of interest and register. View the session to fulfill the CME credit, and then receive certification online. We want to remind everyone that the NMOSD Grand Rounds series now has a number of presentations available, including the presentation today from Dr. Abu. The next presentation will be best practice care of patients in special populations, and this includes pediatrics, elderly, and other populations. Once again, please visit the Education Center of the Guthy-Jackson Charitable Foundation. You see the QR code here. In addition to the NMOSD Grand Rounds series, you will find there a number of educational events and many other resources, including presentations and multimedia opportunities. We greatly appreciate Alexion and the AstraZeneca Rare Disease Division for sponsoring the Guthy-Jackson Charitable Foundation NMOSD Grand Rounds. We really appreciate their support of education. And again, thank you all for attending this session of NMOSD Grand Rounds.